the budget is very high in Indian population. So you all know that the 21 crores of the patients by 2025, it was a projection given by the WHO 10 years ago, but the actual figures are 33 crores. So the prevalence of the hypertension is increasing day by day, and today it is more than 30%, 30.7%, and then one in every 3 Indian adults is an hypertensive. So imagine the number of the hypertensive living in the Indian population. And the most troublesome here is the young individuals, age group between the 20 to 44. I can say even post intermediate, between the 17 and 18 years, is the very early age to have the hypertension in Indian population because of the lot of the stress and the strain they go through in Chaitanya and Narayana schools. Hypertension is one of the leading risk factors for the global mortality. Nearly 50% of all deaths from the stroke and the heart disease. CV risk doubles with each 20 by 10 millimeters of mercury rise in the blood pressure, the systolic and the diastolic. But here, the list starts from 115 by 75. So all these years we thought that hypertension is very dangerous, high BP is very dangerous once it crosses 130. But if you see the actual reality, all the risk of the hypertension will start when the blood pressure is more than 115 by 70. So your target blood pressure in all our hypertension population should be less than 120 by 80 rather than 120 by 90. So what about the hypertension control rate in India? In spite of a lot of the drugs in our hand, we have the very beautiful hydrochlorothiazide, chlorothalidone, and then the beta blockers, calcium blockers, ACE inhibitors, ARBs, and also the newer drugs, vasodilators, etc. But still, unfortunately, 17.5% is the figure of the reached hypertensive individuals with a target blood pressure. So that means a lot to be done to diagnose the hypertension at the right time, to initiate on lifestyle measures, on the dietary modifications, on the exercise and yoga, meditation, and start monotherapy, and then upgrade the monotherapy to the combination therapy, and finally you have to reach the target blood pressure of less than 120 to 80. Otherwise, still today, nearly 87% of the population are having the hypertension. Unfortunately, it is a silent killer because the most symptoms of the signs in about 80 to 85% of the hypertension individuals left untreated definitely will lead to not only the heart failure, but also the coronary artery disease, cardiomyopathies, strokes, cerebrovascular diseases, either both the ischemic and the hemorrhagic peripheral vascular diseases, retinopathies, and also the most important is the CKD. If you reduce the blood pressure by each 10 millimeters of mercury in the systolic blood pressure, you can reduce the CV death by 13%. The same thing with 5 millimeters of reduction in diastolic will reduce the CV death by 14%. See, stroke risk is also doubles with the hypertension control. This is the underlying mechanism of the hypertension differs between the young and the old. This is very important because in a country like India, with the highest number of hypertensives in the world, unfortunately, about 40 to 50% of the hypertensives in India are young Indians. So the young hypertension and the old hypertension. In young hypertension, the national will be more than the 90, systolic will be more than the 140. The old hypertension, the systolic, more than the 140, and also the diastolic less than the 80 because of the wide non-structure, because of the elderly individuals, or maybe because of the other things, hypertension and military conditions. So in hypertension, you will have the diastolic hypertension. Males are more important here. High BMI at the baseline, so the obesity is also increasing. Increasing weight during the follow-up and the high peripheral resistance. So here the main mechanism in the young individuals is the peripheral resistance, maybe the sympathetic overactivity, etc. Whereas the old individuals, it is the peripheral vascular resistance or the vasoconstrictions, etc. That is the reason in old hypertension we use the calcium blockers and use the ARBs, etc. And you divide the hypertension into two groups. One is uncomplicated and complicated. So unfortunately, in India, most of the complicated hypertension we see because of the coronary artery disease, congestive heart failure, increased sympathetic activity, arrhythmias, etc. Here there is a compelling indication to use the beta blockers. So of course, if you see the role of the beta blockers in the uncomplicated hypertension, don't use it. When the hypertension is there, the elderly population will start with the calcium blockers and daily. When the hypertension is seen in the ideal users, we start with the bisoprolol and ARBs. But there is a compelling indication to use the beta blockers in all these population once they have the cardiac problems, like maybe the heart failure or the cardiac disease or tachyarrhythmias. You all agree with me that the outcome of the hypertension inhibitors, they need a combination. You see, whatever the trials, they all say that most of our hypertension inhibitors, 90% of the hypertension inhibitors, they need 2 or 3 or sometimes the 4 drugs also. Then you consider it as a resistant hypertension. So this slide clearly shows that don't be happy that monotherapy. Most of the they need combination. And resistant hypertension, the clinical practice in India, this is the Jaipur Heart Watch. Shows 1 in 5 patients with hypertension in India have the resistant hypertension. So that means they are already on the 3 drugs, hypertension drugs, but still the blood pressure is lower, above 130. So they need 4 drugs. So in all these drugs, your ARBs and the calcium they need the 4th drug as a spinal blocker or an alpha blocker, alpha beta blocker, etc. So there is always a role to use a many antihypertensive medications in at least 25% of the. So you should know each and every molecule of the antihypertensive medications. Heart rate is very important in hypertension management because heart rate may be an independent risk factor for cardiovascular death in persons with hypertension. So tachycardia means not more than 100. That is a bookish tachycardia, but a clinical tachycardia is more than 90. So once the heart rate is more than 90 in all the hypertensive individuals, you have to use some drugs which reduces the heart rate. But here, the beta blockers are very important, like the bisoprolol. Sympathetic overactivity in Indians is very high. It's an important role in the development of both hypertension and also its related cardiovascular diseases. So sympathetic overactivity increases on heart rate, elevation of systolic blood pressure, cardiac output, sodium reabsorption, and also the high interferon values, etc. So all these people with a sympathetic overactivity, so definitely there is a role of the beta blockers to use them. High renin levels in Indians when compared to the Caucasians, nearly 45% of Indians are so how to use the drugs which reduces the like your ARBs and so choice of the beta blocker matters. You have the propranolol, you have the etalol, you have the metoprolol, you have the nivolol, carvedilol, etc. So why the beta bisoprolol? You can use it most of our hypertension. If you classify the beta blockers, they have the 2 groups. One is the no intrinsic activity, and the other group is intrinsic activity. Here the beta blocker, beta 1 selectivity, beta 2 selectivity, beta 3 selectivity, etc. These are the different mechanisms of the beta blockers. They reduce the heart rate by blocking the beta 1 receptor and reduces the cardiac output. The beta blockers they also reduce the renin release like your ARBs. So the beta blockers not only active in the heart to reduce the heart rate and the cardiac output, they also act on the kidneys to reduce our renin levels. So these are the pharmacokinetics of the different beta blockers like bisoprolol, etalol, metoprolol, nivolol, etc. Here the plasma elimination half-life is more than the bisoprolol. That's truly once again, unlike your etalol which acts for about 14 hours and the metoprolol acts for about 16 to 18 hours. Absorption more than the 90%, availability is also more than the 90%. If you see the pharmacokinetic variability, it is very low with the bisoprolol and very high with the metoprolol. So in all the diabetes and hypertension, we have the glycemic variability and the BP variability. So the BP variability is very important because if you keep the BP variability high, so definitely we are inviting a lot of the complications. To reduce this BP variability, we have the molecule like the bisoprolol. It has 19.6-fold higher affinity for the beta 1 receptor, so there is more of cardio specific and the renal specific rather than to reduce your COPD and bronchitis. So they won't cause any side effects when the beta 1 selectivity is very high. The same if you compare the nebula also, so the bisoprolol scores for the nebula in having the high beta 1 selectivity. So the problems with ethanol already told you the half-life, and also the ethanol will cause a lot of the side effects like the metabolic side effects, and also it increases your uric acids, increases your blood sugars, etc. So that is the reason we are not using it. So this is the beta 1 selectivity to reduce the heart rate, to reduce the contractility, to reduce the blood pressure, less bronchoconstriction. So the drugs with high beta 1 selectivity will have the less bronchoconstriction, so that can be safely used in all the COPD and also the CKD and the cardiomyopathy cases. So as I told you that the lipids and the glucose metabolism are not disturbed by the bisphenol, like sorbitol and metabolol. So the metabolism here is a 50% unchanged, 50% metabolized, so that can be safely used in all the hepatic and also the nutrition. Sexual dysfunction is very, very low with the beta blocker. Bisoprolol, unlike your etanol and other drugs. It has a unique activity that the flexible dose timing, lesser dose is required, convenient once a go, lesser drug reactions, lesser chance of the central side effects that doesn't cross the blood-brain barrier, so they won't cause the nightmares and etc. And those adjustments in hepatic and the renal damage will cause 50% increase. The consistency and the predictable response which are fully once a the people having these risk factors like your hypertension with the diabetes, smokers, hyperlipidemia, obesity, hyperhomocysteemia, hyperuricemia, microalbuminuria, elevated intimal thickness, elevated ankle breaking index, etc. So these are the both the classical risk factors and also emerging risk factors. We are seeing a lot of them with hypertension. In left ventricle, what they do? So they go on to have the left ventricular hypertrophy, which is an independent risk factor for the ischemic heart disease and the heart failure and the CKD, and more atherosclerosis accounts the correction of these risk factors. So they cause myocardial ischemia, then the thrombus formation, finally myocardial infarction. And after the myocardial infarction, two things may happen. So the people may go for the sudden death, or maybe the remodeling of the ventricle. So there will be the left ventricular enlargement to cause congestive heart failure and death. And finally, a resistant heart failure and cardiac death. So to block this, so we have the few drugs like beta blockers, especially on bisoprolol, which can act on the different pathways. It can reduce your LDH. It is a drug of choice. One of the important drugs to be used in coronary artery disease. They can be used in the tachyarrhythmias. So very important, one of the four pillars in the management of the heart failure. So the beta blockers of the bisoprolol is having a role in all these pathways. The national consensus statement on the role of the bisoprolol across the cardiovascular continuum, special focus on the women. So this is the APA. Said that bisoprolol's cardioactivity, metabolic neutrality, minimal side effects make it the preferred choice for women with the CVD, particularly those with the comorbidities like diabetes, etc. So a lot of more hypertensives are having the comorbidities. Only 1% of hypertensives are hypertensive. If you see that clinically, all hypertensives will have the comorbidities like diabetes, dyslipidemia, obesity, etc. So resultants of the beta blockers, because of the increased incidence of the cardiac problems, now the beta blockers are the compelling indications to use in our armamentarium. So these four drugs you are all aware of it: ABCD, A's or ARB, beta blockers, calcium blockers, diuretics. So definitely more than the 50% of our hypertensive users need these combinations. So as I told you that a combination therapy is very important from the day one. So once then you can use either the ACE beta or calcium blockers at the diuretics. Finally, all the three drugs we have the single pills. A lot of the single pills are there with the ARBs, CCPs, and the diuretics. And beta blockers as a monotherapy, or you can combine it any time. So the CV outcomes, CV mortality and all-cause mortality, they are very well reduced with the beta blockers. So that is the reason these are beta blockers that drugs to reduce the mortality. So the mortality benefit will be seen with the beta blockers. Bisoprolol, they reduce the BP and also reverses the LVH. If you compare the enlapril, one of the important ACE inhibitor, because ACE inhibitors and ARBs, we don't consider them as a pure antihypertensive medications. They reduce the blood pressure. Also, they are vascular protective, renal protective, or cardio protective. So see the difference between the bisoprolol and the enlapril. So almost equal to the enlapril. And if you see the left mass reduction, it is more the bisoprolol when compared to the enlapril of. In the same way, the bisoprolol shows the superior improvement in the left ventricular diastolic function. So what is the most common diagnosis in the 2D echo nowadays? A more than E, a diastolic dysfunction. So the diastolic dysfunction is very common because of the hypertension, because of the diabetes, because of the IHP, etc. So here, using the bisoprolol, we are improving the E/A ratio. So that means we are not allowing these people to go into the diastolic dysfunction. So bisoprolol is unique to PK and PD, pharmacokinetic and pharmacodynamic profiles. Induce predictability and ease of the use. Reduces the mortality, that's very important, and also the CV events in the heart failure. So now you know the heart failure is divided into three groups. One is the range of mildly reduced ejection fraction. These are the four pillars to use the drugs in heart failure. ACE or ARB are harmony, mRNA. Now the steroid sparing is also available. SGLT inhibitors very useful. Beta blockers of beta high selectivity like this. See the bisoprolol reduced all-cause mortality and the sudden deaths. Here the 54% of the patients were treated with bisoprolol. Will be 7.5 mg or the 10 mg. 46% sudden death reduction is seen with the bisoprolol therapy. And it's a very good combination, the beta blocker and the ARB. I think 80 to 90% of our population. So they are in this combination. So bisoprolol reduces the SMS. Reduces the mass activity. So clinical situations where the bisoprolol and the telmisartan are useful, all the hypertensive individuals with high heart rate, with sympathetic overactivity, the compelling indications like cardiac compelling indications, with the CKD, and with the metabolic disturbances. Now the combination of the bisoprolol and the amlodipine. In fact, the best antihypertensive medication is the amlodipine, the calcium and blockers, because of the simple vasodilators. So here the bisoprolol they have both on the heart to reduce your maintenance activity and the kidneys to reduce your renal activity. The amlodipine is a peripheral vasculature will be reduced. They will have the vasodilatation. So these are all having advantages. Especially in the stroke individuals. So in the neurological cases, so we use a lot of the calcium channel blockers, the beta blockers, etc. The elderly hypertensives, again the calcium blockers are the of the choice. Smokers, CKD, and COPD. So this combination is better. And if you compare the metoprolol and the ribulan and the bisoprolol, so if you see the heart rate reduction is more the bisoprolol compared to the metoprolol. If you see the survival benefits and the superior heart rate reduction is more than the bisoprolol compared to the. So across the cardiovascular continuum, you can use the beta blockers because they reduce the vascular inflammation. So that can be easily detected in our patients by getting your high sensitive CRP. So most of our people will have high sensitive CRP more than 10. So that shows the vascular inflammation. So more and more atherosclerosis, etc. So to reduce all these things, also finally to reduce the mortality. So there is always a role to use the beta blocker of this propagation. Recording of CAD value in India very very high, 3 times higher CAD rates in Asian Indians even after the migration. Even in the 17 years, because of our Indian origin, they have the higher risk of the CAD. 1 in 4 deaths in India are known because of the IHD. There is an escalating trend with about 50% increase between 2007 and 2017. I think now this time there will be an increase of 60 to 60%. What are the unique features of the Indian coronary artery disease? Unfortunately, younger age at presentation, even at the age of 40 years, 30 years, so they are having the 2 PTCAs or primary CLBGs. The very rapid progression, high mortality rates, multivessel disease, diffuse involvement, distal disease, significant nephrological dysfunction, ejection fraction 28%, 30%. Now the beta blockers, they well established cornerstones in the management of the IHD. So without the beta blocker, the prescription of the IHD, the post MI or post PTC or post PNBT should not be there. We should include beta blocker in all these population because it triggers the thermometric process, reduce the rate of the reinfarction, reduce the infarct size and risk of the cardiac rupture, increase the threshold to the ventricular fibrillation, reduction of the platelet thickness, reduce the myocardial oxygen requirement, etc. So all these features will make the beta blockers as a compelling indication to use in this population. Earlier we used to write a lot of the Bisoprolol. Now the Bisoprolol is gaining out. All over the other parts of the world, the Bisoprolol is the number one beta blocker to be used in the CAD. So it's used commonly in the current practice. Even in the stable CAD or the acute coronary syndromes in the ICUs or the tachyarrhythmias, there is always a role of the beta blocker. Association of beta blocker therapy with the cardiovascular outcomes, the stable ischemic heart disease. Here the sample size is nearly 30,000 population. See the composite death results. Beta blockers have a 13% relative reduction in the hazards of the hospitalization for the infarction, 8% reduction in the hazards of the primary outcome. This other study interrupted the beta blocker therapy in some individuals. In some individuals, they continued nearly 2,000 each. So when they interrupt the beta blocker therapy, there is no improvement in the quality of the life, and 16% risk increases in the death. What are the long-term effects of the beta blockers? Very good. Long-term effects improve the prognosis, independent of the people learning effect of the beta blockers. Longest and the largest Bisoprolol group here, they also showed that death rate is also reduced with the beta blocker therapy. So you know this classification of the heart failure. The ejection fraction less than 40, graph more than 50, between 40 and the 50. Earlier we called as the minimal mildly reduced products, mildly reduced. In all these conditions, we have to use the beta blockers. Even the low dose or high dose or the moderate dose, they tolerate it very well, and we have a survival benefit. In atrial fibrillation, tachycardia induced heart failures, cardiomyopathies. In arrhythmias, supraventricular arrhythmias and ventricular arrhythmias, a compelling indication to use again the beta blocker Bisoprolol nature. Early Bisoprolol initiation within the 4 hours reduces the inpatient CV complications. Effective treating. In all the tachyarrhythmias, they have the use. CKD pattern, so definitely Bisoprolol balance and clearance is a very important since failure of one clearance organ leads to a maximum of the twofold increase. So it's a low dialyzability beta blocker, so can safely use even the phenols and the analysis. Thank you very much for your question.